Long before it beats, the human heart begins as a simple sheet of cells called cardiogenic mesoderm, rolling itself into a primitive biological tube. As it matures, it develops into a hollow, muscular organ. Its singular objective is to operate as the central pump of the cardiovascular system, forcefully driving blood through vessels to deliver nutrients and remove tissue waste. Mapping the heart's exact coordinates. Anchored in the middle mediastinum, it lies obliquely, 2/3 left of midline, spanning the second rib to the fifth intercostal space. The left ventricle forms the downward apex. The posterior left atrium forms the base. Textbook diagrams often flatten this complex geometry. To actually understand clinical cardiology, we have to look past two-dimensional memorization. We need to systematically assemble the mechanical architecture of this organ from first principles, layer by layer. We begin construction with the internal dividing walls. The interatrial septum splits the upper section, while the interventricular septum, comprised of both muscular and membranous tissue, divides the bottom. This creates a strict division of labor. The right and left atria act as low-pressure receiving chambers, while the right and left ventricles serve as the high-pressure ejection pumps. Because they perform different tasks, their physical structures differ dramatically. The left ventricle drives blood through the entire systemic circulation, requiring immense muscular thickness. The right ventricle only pumps to the nearby lungs, so its walls are significantly thinner. Inside, the right atrium features the crista terminalis ridge, pectinate muscles, and the fossa ovalis depression. The ventricles contain web-like muscular ridges called trabeculae carneae, while the right ventricle uniquely holds the moderator band, a thick bridge spanning the chamber. Every ridge and variation in wall thickness is a physical adaptation. The internal asymmetry is precisely calibrated to manage the disparate pressure requirements of incoming venous return versus outgoing arterial flow. With the chambers built, the pump requires mechanical hardware to enforce strict one-way fluid dynamics. The atrioventricular valves separate the chambers. The right tricuspid valve has 3 cusps, while the left mitral valve has 2. During ventricular contraction, fibrous chordae tendineae tether these valves to the papillary muscles, preventing backward prolapse under high pressure. Guarding the outflow tracts are the semilunar valves, the pulmonary and the aortic. Unlike the AV valves, these do not rely on muscular tethers. Instead, their pocket-like cusp geometry catches reversing blood, snapping shut under pressure. Without this structural anchoring and geometric precision, the high-pressure gradients generated by the ventricles would instantly collapse into fatal multidirectional flow. Mechanical components require a synchronized trigger. This is provided by the conducting system, the autonomous electrical wiring. The sinoatrial node in the right atrium sparks the electrical impulse. It travels to the atrioventricular node, stalling briefly to allow ventricular filling. The signal then accelerates down the bundle of His, splits into bundle branches, and rapidly distributes through the Purkinje fibers. While this system is intrinsic, it is modulated by external autonomic nerves. Sympathetic nerve supply increases the rate and force of contraction, while parasympathetic signals slow the rhythm down. These electrical pathways guarantee that the mechanical structures fire in a synchronized bottom-up sequence, ringing the blood upward toward the outflow valves to maximize efficiency. Despite pumping thousands of gallons of blood every day, the thick myocardial walls cannot extract oxygen from the fluid inside. They require an exclusive external vascular network. This vascular network routes through exterior surface grooves called sulci, the coronary sulcus, and the anterior and posterior interventricular sulci. The right coronary artery traces these grooves, branching into the right marginal and posterior interventricular arteries. Crucially, this right-sided arterial supply is typically responsible for fueling the SA and AV nodes, meaning the electrical timing of the heart depends on this specific vessel. On the opposite side, the left coronary artery splits into the circumflex artery and the critical anterior interventricular artery, widely known as the LAD. These branches distribute a dense arterial network over the thick left ventricle. Once the oxygen is extracted, the great, middle, and small cardiac veins route it to the coronary sinus, which empties directly back into the right atrium. Operating in parallel, a lymphatic drainage system removes excess interstitial fluid, routing it outward into the tracheobronchial and mediastinal lymph nodes. This localized, dense coronary network is the pump's Achilles heel. The immense workload of the contracting myocardium makes it uniquely vulnerable to any interruption in these specific fuel lines. Now we connect the main plumbing. Deoxygenated blood feeds into the right atrium via the superior and inferior vena cava, while 4 pulmonary veins deliver oxygenated blood into the left atrium. Exiting the pump, the pulmonary trunk channels blood from the right ventricle toward the lungs, and the massive aorta arches out from the left ventricle to drive the systemic circulation. The organ is anchored inside the pericardium. The tough, inelastic outer shell is the fibrous pericardium. Inside lies the serous pericardium, split into a parietal layer and an inner visceral layer. A microscopic gap between them contains serous fluid, providing a frictionless environment. The cardiovascular pump is now fully assembled, a self-regulating, continuously fueled, mechanically anchored machine operating inside a frictionless vacuum. With the parameters of the pump defined, cardiovascular disease can be understood for what it actually is: an engineering failure of specific anatomical components. Take a myocardial infarction or heart attack. If a single coronary branch, like the LAD, becomes blocked, the dependent ventricular muscle is starved of its fuel supply, resulting in rapid tissue death. The precursor to this total failure is angina pectoris, where the blood supply is severely reduced but not fully obstructed, causing sharp chest pain as the muscle strains under exertion. External structures fail just as dangerously. If the pericardium becomes inflamed, a condition called pericarditis, excess fluid begins to accumulate within the pericardial cavity. This triggers cardiac tamponade. Because the outer fibrous pericardium is entirely inelastic, it refuses to stretch. As fluid increases, pressure has nowhere to go but inward, mechanically crushing the underlying chambers and preventing the right ventricle from filling with blood. Internal hardware degrades as well. Valve stenosis occurs when the leaflets stiffen and restrict the outflow of fluid. Conversely, regurgitation happens when the cusps or the chordae tendineae fail to close tightly, allowing blood to leak backward against the intended current. There is no dividing line between anatomy, physiology, and pathology. The ability